In the discussion of vascular pathology, our next topic is granulomatosis with polyangiitis. This granulomatosis with polyangiitis, formerly known as Wegener's granulomatosis. So, it is also a vasculitis, and like other vasculitis, the mechanism of this vasculitis is also unknown. So, it is a multi-system disease of unknown etiology. So, the cause is idiopathic over here, the etiology is unknown. So, like other vasculitis, Wegener's also have idiopathic etiology. So, if we talk about etiology, unknown etiology. This is one important MCQ question, and it is characterized by the vasculitis and necrotizing granulomatous inflammation of the small arteries and veins. So, there is necrotizing granulomatous inflammation, necrotizing granulomatous inflammation of arteries and veins. Etiology is unknown. It is the necrotizing granulomatous inflammation of arteries and veins. So, for the diagnosis of this Wegener's granulomatosis, we need to identify the triad of symptoms. So, here we will write GPA triad. What are the triad of clinical manifestations we will see in granulomatosis with polyangiitis? In this, the first one will be the necrotizing granulomas of the upper and lower respiratory tract. So, the first manifestation will be necrotizing granulomas of lower respiratory tract and upper respiratory tract. Initial manifestations in the triad, or the first clinical manifestation what we will see in the Wegener's will be necrotizing granulomas of lower as well as upper respiratory tract. And second one in the triad is systemic necrotizing small vessel granulomatous vasculitis. Second one will be systemic necrotizing vasculitis, that is granulomatous vasculitis, systemic necrotizing vasculitis, that is granulomatous vasculitis. And third one in the triad is glomerulonephritis, that is especially of crescentic type of glomerulonephritis is an important MCQ question. Remember that whenever we discuss about the triad of symptoms of GPA, we have 3 points in the triad, right? First one is the necrotizing granulomas of upper as well as lower respiratory tract, and remember that the initial manifestations of Wegener's will be necrotizing granulomas of upper respiratory tract followed by lower respiratory tract. So, necrotizing granulomas of LRT as well as URT, systemic necrotizing vasculitis, that is granulomatous vasculitis, and glomerulonephritis, which is crescentic type of glomerulonephritis. And remember that in less severe forms or limited forms of this disease will only affect respiratory tract, which means in less severe forms of Wegener's, we cannot see the necrotizing granulomatous inflammation in other parts of the body. It will be restricted only to the upper as well as lower respiratory tract. That means the upper respiratory tract involvement, that is ear, nose, throat. Upper respiratory tract involvement, that is ear, nose and throat, is the first and the most common organ or the anatomical area to be involved. So in 95% of the cases of Wegener's, you can see the involvement of ear, nose and throat. So the upper respiratory tract manifestations are seen in 95% of the cases, and these are the initial manifestations of Wegener's. This is the MCQ question. What are the initial manifestations of the Wegener's? Lung manifestations or upper respiratory tract manifestations? Upper respiratory tract manifestations are the initial, most common, as well as seen in 95% of the cases, followed by the lower respiratory tract manifestation called as lung manifestation. First will be upper respiratory tract. After the involvement of the upper respiratory tract, then it will spread to lungs. So lungs will be the second manifestation of Wegener. So this is the first clinical manifestation, will be the necrotizing granulomatous inflammation of the URT. Next will be necrotizing granulomatous inflammation of the lung because of the involvement of lower respiratory tract. And remember that upper respiratory tract involvement causes this. Upper respiratory tract involvement causes this one. Important features: involvement of the upper respiratory tract causes nasal septal perforation. Here it will be nasal septal perforation. Second one will be strawberry gums. We studied strawberry tongue in the Kawasaki disease. So strawberry tongue is specific to Kawasaki disease, but strawberry gums is specific to Wegener's granulomatosis. So next will be strawberry gums, is an important MCQ over here. And next clinical manifestation will be because of the involvement of the ear, otitis media may be seen. So otitis media as well as hemoptysis. So because of the involvement of upper respiratory tract, ENT manifestations are nasal septal perforation, strawberry gums, otitis media, hemoptysis, right? So along with upper as well as lower respiratory tract involvement, other organs are also affected in the Wegener's, but in the later course of the disease, or we can say in the severe forms of the disease. So other organs affected by the vasculitis are skin, which causing palpable purpura, eye involvement, involvement of the joint in the form of non-erosive migratory arthritis. Peripheral nerve involvement can also be seen, but it is extremely rare in the form of mononeuritis multiplex. And in least number of cases, we can also see the involvement of gastrointestinal tract. All the other anatomical areas can also be involved, but in most severe forms, but in later course of the disease. So when we discuss about the involvement of lungs specifically over here, the lung involvement has two pathogenic mechanisms. First is vasculitis. Vasculitis is the first pathogenic mechanism. Next one will be formation of necrotizing granulomas, right? Two important pathogenic mechanisms are seen in the manifestations of lung. First one will be vasculitis. Next one will be formation of necrotizing granulomas in the lung substance. So remember one important point over here, that all other organs are affected by vasculitis after the involvement of LRT as well as URT, but the granuloma formation is extremely rare in other organs, and it is more commonly seen in the lung as well as in the URT, right? So the granuloma formation is more commonly seen in the upper as well as lower respiratory tract, including lung, but these are less common in other organs. That's the reason granuloma formation is rare in other organs and more commonly seen in the lung as well as in the upper respiratory tract. So because of the granuloma formation is seen in the lung, we can see the X-ray which clearly shows the cavitary lesions. So in the lung, so here let me write lung lesions, we can see cavitary lesions. One can see the cavitary lesions on the X-ray. What you will see here, this is an important MCQ point because of the formation of the granulomas in the lung. So here, whenever we talk about less severe forms of wegeners, that is limited wegener's granulomatosis, is characterized by involvement of only respiratory tract and no other system. Limited wegener's granulomatosis is characterized by involvement of only respiratory tract but no other system, which means whenever we talk about less severe forms of wegeners, right, limited forms of wegeners, you can see the necrotizing granulomatous inflammation only in the upper as well as lower respiratory tract, not in other anatomical areas. Only in the most severe forms or later stages of the disease only you will see the involvement of the GIT or nerves or joints or other organs, right. Now, this granulomatosis with polyangiitis most often occur in patients of middle age, that is middle-aged males. It is more commonly seen in males which are of middle age, and the mean age of this wegeners is 40 years. So let me write over here itself males, male predominance, and mean age is 40 years. Unknown etiology, more commonly seen in males, mean age is 40 years. The pathology is necrotizing granulomatous inflammation of the arteries as well as veins. We have a triad of clinical manifestations. The first one is necrotizing granulomas of upper as well as lower respiratory tract. Initially, 95% of the cases, the initial presentation will be in the upper respiratory tract with the involvement of ear, nose and throat, which shows the clinical manifestations like nasal septal perforation, strawberry gums, otitis media, hemoptysis. Later, there will be an involvement of lower respiratory tract in the formation of granulomas in the lung, right? Formation of granulomas in the lung, that is cavitary lesions in the X-ray can clearly show that the granuloma formation in the lungs. And second manifestation in the triad is the systemic necrotizing vasculitis, right? That is systemic necrotizing granulomatous vasculitis. And the third one will be glomerulonephritis because of the involvement of the kidney. But the type of glomerulonephritis is crescentic glomerulonephritis. This is the MCQ question. And X-ray shows the cavitary lesions because of formation of granulomas in the lower respiratory tract, that is lung, right. So that is the reason you have to remember that it is more commonly seen in the males, that is at the age of 40, and more commonly seen in Northern European origin. So the wegeners are more commonly seen. If you take 100 cases, 80 to 90% of the cases of worldwide are seen in Northern European origin, right. Now, when we talk about the lab values, the wegener GPA is positive for both C as well as P type of anti-nuclear cytoplasmic antibody. So here another important MCQ question is positive for CANCA as well as PANCA. Both are positive, but not in all the individuals. Approximately 96% of the patients are positive with CANCA and 25% of the patients are positive with PANCA. So which one is more specific, C or P? C is the most specific one. If you see the options, even though we say in the lecture that the wegeners is positive for both C as well as P, if you see the option C as well as P in the exam, you have to choose C because of the more specificity, that is 96% of the cases you will see positive CANCA, and only in 25% of the cases we can see positive for PANCA. But we cannot exclude that PANCA is not there. That's the reason we can say the sentence that the Wegener's granulomatosis are positive for both CANCA as well as PANCA. When they ask about specificity, then you should say that approximately 96% of the cases they are positive for C type and 25% of the cases they are positive for P type, P antinuclear cytoplasmic antibodies. Now, let us talk about the classic features of Wegener's granulomatosis. So, here let us write classic features of Wegener's granulomatosis. Classic features. MCQ question, very important topic. Classic features of Wegener's granulomatosis. Persistent pneumonitis with bilateral nodular and cavitary infiltrates. Persistent pneumonitis, that is bilateral or unilateral? It is bilateral. Bilateral nodular and cavitary infiltrates. So, bilateral, cavitary, that is nodular, cavitary infiltrates are seen in 95% of the cases. So, this is more specific for Wegener's granulomatosis. Persistent pneumonitis with bilateral nodular cavitary infiltrates are seen in approximately 95% of the cases. And chronic sinusitis, chronic sinusitis is seen in approximately 90% of the cases. That is the reason I am calling it as classic features of Wegener's. In 90% of the cases, because of the involvement of the upper respiratory tract, we can see chronic sinusitis, right? And also, we can see the mucosal ulcerations of the nasopharynx in 75% of the cases. So, mucosal ulceration of nasopharynx in approximately 75% of the cases. 75% of the cases we can see mucosal ulceration of the nasopharynx. And at last we have to discuss about the involvement of the kidney, that is renal lesions. Renal lesions are the later manifestations of Wegener's. Renal lesions are seen in 80% of the cases. So, once you identify renal lesions, you have to say that the disease is at advanced stage, right? So, these are the classic features. What are they? Persistent pneumonitis with bilateral nodular cavitary infiltrates are seen in 95% of the cases. Chronic sinusitis is seen in 90% of the cases, right? Mucosal ulceration of nasopharynx is seen in 75% of the cases. Renal lesions are seen in approximately 80% of the cases. So, these are the classical features of Wegener's granulomatosis. Now, let us talk about the best tests. Histologic criteria are necessary for the definitive diagnosis. So, in this ANCA, we already discussed about this. ANCA with a true cytoplasmic staining is sensitive in patients with active generalized GPA. That is, as we already discussed, that it is positive for both C as well as PANCA, but most specific for CANCA. Right? Now, let us talk about the treatment of GPA. So, in the treatment, what is the treatment of choice will be the question in the exam. So, in the exam they will ask you what will be the, let me write here, TOC, treatment of choice, MCQ question. Treatment of choice, CP, cyclophosphamide with steroids. Cyclophosphamide is the treatment of choice. We always give in combination with steroids, right? This is the treatment of choice. So, what is the second line? This is the first line of treatment. The treatment of choice will be cyclophosphamide in combination with steroid. For example, if cyclophosphamide is contraindicated in some individuals, or if the patient develops cyclophosphamide toxicity, then we need to give methotrexate plus steroids. Cyclophosphamide plus steroids is the treatment of choice. If cyclophosphamide is contraindicated for any reason, or if the patient has experienced significant cyclophosphamide toxicity, then we need to change the drug to methotrexate. Then we have to give in combination with the steroid, will be the alternative therapy, or we can say the second line of therapy in Wegener's granulomatosis. And this is what is about Wegener's granulomatosis. So let me have a very quick review about the Wegener's, because there are so many important MCQs which can be seen from this topic, guys. So the etiology is unknown, more commonly seen in the middle-aged males. Approximately the mean age is 40 years, and it is a necrotizing granulomatous inflammation of the arteries as well as veins. So this GPA has a triad of symptoms like necrotizing granulomas of LRT as well as URT. The second one in the triad will be systemic necrotizing vasculitis, that is granulomatous vasculitis is the second point in the triad, and the third point in the triad will be glomerulonephritis, that is crescentic glomerulonephritis called as renal lesions. And remember, the first manifestation will be the involvement of the upper respiratory tract. ENT structures are involved, and they are considered to be the first initial clinical manifestations what we can see in the Wegener's. Approximately we will see in 95% of the cases. So whenever we discuss about the ENT symptoms, we need to say that nasal septal perforation, strawberry gums, otitis media, hemoptysis are like considered to be the upper respiratory tract manifestations. Later we can see the manifestations of lower respiratory tract in the form of lungs. So in the lungs we can see the cavitary lesions in the lungs, we can clearly see in the X-ray, as well as remember that these are positive for both CANCA as well as PANCA, but CANCA has more specificity when compared to that of PANCA, because it is seen in approximately 96% of the cases, and PANCA is seen in approximately 25% of the cases. Whenever we discuss about the classical features of the Wegener's granulomatosis, we have to say that there is a persistent pneumonitis with a bilateral nodular cavitary infiltrates, which can be seen in 95% of the cases, with chronic sinusitis in 90% of the cases. Mucosal, like nasopharyngeal ulceration of the mucosal will be 75% of the cases. Renal lesions are seen in 80% of the cases. Renal lesions indicates severity of the disease, as well as whenever we discuss about the tests which are positive for CANCA will be the gold standard. Histological staining will be gold standard for the diagnosis of this Wegener's granulomatosis. Whenever we discuss about the treatment of choice, cyclophosphamide in combination with the steroid can consider to be the treatment of choice in the Wegener's. If cyclophosphamide toxicity can be seen, then we have to give the alternate therapy, that is methotrexate in the combination with the steroid therapy can be given as second line of therapy. This is what we need to know about Wegener's granulomatosis.